So we will start and see how can we start doing a total hip arthroplasty using the SPAIRE approach. The SPAIRE approach was a technique that was first described in 2017 in the Hip International, and it's a modified posterolateral approach in which we spare the piriformis and obturatus internus together with the gemelli. So it's an approach that it's very anatomic and it's very helpful if you want to spare most of the muscles from the short external rotators. So we have been seeing some results of using this kind of approach, especially compared to the standard lateral or the posterolateral approach, and also with some follow-up like 3.5 years, but I will go back to that later. So the SPAIRE approach means that we can save the piriformis and obturator internus together with the gemelli insertions. We just detach the obturator externus and then we repair it in the end of our surgical procedure. So it results that the only tendon that is released and subsequently repaired is the obturator externus. So we spare a lot of muscles and we gain a lot of function on our postoperative when we versus a standard posterolateral approach. There's also a lot of plus in this approach, especially when you compare it to other so-called mini-invasive or anatomic approaches like the direct anterior. We don't need no special equipment, no special table. We can use all types of stems when we do this kind of approach. So if we get in troubles because of the anatomy, or even if we have some intraoperative complication like a femoral fracture, or any other kind of intraoperative problems, it's easily converted or extended to a standard posterolateral approach, or even into an ETO, or even for solving very distal fractures, even at the tip of the stem. We don't have any problems with patient selection, so we don't need to limit this approach we can use it even in severe hip dysplasia cases. We can use it in SCIFI, or Perth or Lech Perthes cases. So all patients are suitable for this approach, even if we had to do some releases other than the obturator externus. So we get an approach that has a high stability afforded by maintaining the short external rotators. I don't use any postoperative restrictions or immobilizers in my patients. We can get improved gait, mostly because we have all these muscles functioning very, very shortly after surgery, and we have an anatomic restoration of hip function, which leads to a faster recovery, less pain, and less muscle damage. Even against the direct anterior approach, there is a very good study done by MRI that when we do the direct anterior approach, and actually when we are working our femur and doing even some selective releases of the femur, we tend to damage some short external rotators, and even sometimes the piriformis get detached when we do these releases to pull the femur out and do the femoral side. So this is an approach which we use the interval between the quadratus femoris and the quadriceps coxa. We have those dotted line that are marking the external obturator tendon. That's the interval we are working on. So this is my own image. When we pull the retractors, So on your left side, we have the retractor, retracting the quadratus femoris, and at your right side, we have the quadriceps coxa. You can see that we have the entire capsule exposed, and we have the entire capsule with the femoral neck exposed. So what we do is we tend to build this muscle flap with the quadriceps coxa on the cranial side and leaving the quadratus femoris on the caudal side of the incision. These are actually the images from the original article. So if you get less experience with this approach, you can release the entire quadratus from the femoral insertions and then probably get a better visualization. But actually, if you see this image from one of my cases, you don't need to expose that much. So you can see that when we put the Oman retractor on the cranial side along the femoral neck and over the capsule, you get a very good exposure of the femoral neck and the intertrochanteric crest. You get all the capsule. You can do your capsulotomy if you want to preserve most of the capsule and by the end of the surgery close it. You can actually do it. So what we do is then we do our capsulotomy. We mark our center of rotation, our planned osteotomy according to our preoperative plan. We do the cut at the femoral neck, just like a normal cut, and probably the best way. In your first cases, if you want, you can dislocate the hip, but you will notice that when you are progressing with this approach, and most of the surgeons are used to the posterolateral approach, you don't need to dislocate the hip to do this cut. Then you can just remove the head and the femoral neck with a Schwanzpin. And here, what I think, although you can do it with a normal reamer, I think it's better to use an angulated reamer. You can use the standard 30 degrees angulated reamer from the direct anterior approach, or a special reamer that was built for the direct superior approach, which has 70 degrees of offset, and then you can ream just from above without having to release a lot of capsule to do your acetabular side. And then this is the look you get when you finish your case. You have the quadriceps coxa that it's protecting and crossing in front of your total hip, okay? And most of the times you see that this muscle mass tends to just be or crossing your total hip at the center of rotation of your total hip. And this is what you get when you close the capsule and you do the reinsertion of the obturator externus. So you restore the native short external rotators. And it's also possible to do this with a very small scar, especially if you use the 70 degrees angulated reamer, which does allow you not to open very much on the caudal side of the skin incision, to work all the way through your acetabular component. So what I think it's very, very easy with this approach is that probably limb length and offset are facilitated by the muscle tension and the capsular repair. So you tend to notice that it's very hard on your helper and on your assistant to hold the retractors because of the force that is exerted by the short external rotators. You will feel that he will feel very uncomfortable compared to a posterolateral approach because the retractor that it's placed on the medial acetabular side is very hard to pull on because of the tension exerted by the short external rotators. So this tends to take this approach as being extremely stable against dislocation. The short external rotators act like a tension band. So actually, if we tend to compare the SPAIRE approach and some of the piriformis preserving approaches against the direct anterior approach, the rate of dislocation is actually equal if we do this kind of approach and in which we preserve the muscular and the capsule, the muscular attachments and the capsule without versus a standard posterolateral approach. You will find that there is possible to do this without violating the IT band. So you don't need to cut the IT band. So you almost can do this as a mix between a superior approach and a SPAIRE approach, in which we can go a little bit higher and then use the retractors to just protect the short external rotators and the quadratus femoris and do our total hip. I think we get a better sciatic nerve protection, especially we can visualize it better with a superior approach. And I think also it's better for cosmesis because we do get a very high skin incision and like a direct superior approach, and the patients tend to get they can hide the incision on their clothes. So I think this is a very good video from VuMedi, and you will find it very helpful. This is a video about the SPAIRE technique, and I think the title is very good. It's probably the best of both worlds. It's an approach that allows us to preserve most of the muscular structures and the function of the hip, and probably an approach that if you get in trouble, it's easily converted or easily extended. So you don't need, for example, if you do a direct anterior and you get into troubles with the femur, probably you will end up with two separate incisions, an incision for approaching the Euter space and another incision to solve the problem of a femoral fracture. So also the group from Exeter, where the SPAIRE approach originated, has a very nice tutorial or videos at VuMedi. They are numbered with from 1 to 8 when you can go step by step with this approach. And also for those who are starting to do this and starting to go on switching to robot assisted arthroplasty, there's also a nice video from the Exeter group in which they show you how to do the preoperative plan and also how to work your way switching through robotic assisted arthroplasty. So I would say that the SPAIRE approach, it's anatomic, less invasive. It gets you a highly stable hip arthroplasty. It's easily extensible or convertible. There is normally one tendon cut, which is then subsequently repaired. I don't use no post-operative restrictions or special aids on my patients, and I don't use no special table, no special equipment or fluoroscopy. So if you have any kind of questions or if you need any help switching from your standard approach to this kind of approach, you have my email and you feel free to contact me with any questions or regarding any pearls and pitfalls on this approach.
Thank you, Eurico. Eurico, you can stop sharing. Thank you, Eurico, for sharing your experience with this interesting technique, the SPAIRE.
Yeah.
And Eurico, what is your experience? How many cases have you done with the SPAIRE? And is it hemiarthroplasty or total? I mean, you said it's total hip replacement, but what about hemiarthroplasties?
Yeah, I do all my total hips primary cases with this approach. Okay, so what I've been using, I use the Trident Tritanium from Stryker as my scapular cup and the Accolade as my femoral stem. But I've also used cemented cups, the Exeter stem, and even in some cases the long Exeter stem with this approach. So what I feel, it's very easy. You can use any kind of stems. So you see that probably some surgeons that are starting with probably the direct anterior approach tend to use shorter stems. And one of the problems could be that you are undersizing your femoral stem. I think you don't have these kind of problems with this kind of approach. So I feel that when you are evolving, and that probably for the first, I would say 10 to 20 cases, you will release more than the obturator externus, but then it's getting easier and easier to do it. What I feel is when you have very short necks, or probably very or a very dysplastic hip, probably you will need to release the quadratus, but you don't have to release the obturator internus or the piriformis. So I think it's a question of balancing how much releases you need to work on this space.
Thank you, Eurico. And Eurico, I think original description by John Timperley and others from Exeter is for hemiarthroplasties, right? I mean, their research is primarily on hemiarthroplasties, isn't it?
Yeah, their main study, or they are conducting a study in England, and it's called the SPAIRE, and they are primarily comparing the SPAIRE approach versus the conventional posterolateral approach on hemiarthroplasty. Yeah, in older patients. But I've done some years the direct superior approach, and I feel that with a direct superior approach, you need to release the piriformis and then reattach it at the end. But actually, when I look at the video and the images from the Exeter unit, I was saying, okay, maybe we can do a little bit more superior approach, and we don't need to detach the piriformis or the obturator internus, and actually works very well. I think probably if you need some special, I would say if you want some special equipment, probably the better would be the 70 degrees offset trimmer, and also an acetabular retractor from the direct superior approach, which is a little bit longer and allows your assistant not to do that much strength during the procedure.
And Eurico, just one last question. Eurico, suppose someone is doing the anterolateral approach, okay, the modified Harding or whichever, and if they want to shift to the SPAIRE, what are the technical tips that you would say? Because I am an anterolateral guy, and suppose I want to go with the SPAIRE, what's it?
I would say that it's not about the approach, but it's about how you feel comfortable. I would say that the anterolateral approach or the anterior approach are very good approaches. What I feel is that I was always coming from the posterolateral approach, and I don't do just total hips or primary cases. I also do cases from revisions, fractures. So my thought was I actually my approach. So when I was doing
Eurico, there's an issue with your voice. Yeah.
So can you hear me?
Yeah, it's better.
I was saying that I also do revision cases and fractures. So my thought was, why should I shift from anterior when I was doing primary cases, and then posterolateral for fractures or revision settings. But I would say that probably the most challenging would be acetabular exposure. That's very different from the anterior-based approaches for the posterior approaches. But I would say that it won't be that hard if you want to shift your approach. So I always tell people who visit me or my residents that it's not about how you get to the hip, but the important is to do your total hip, get a stable total hip, I think it doesn't matter the approach you use. If you feel comfortable with your approach, I think probably with the direct anterior, there was also a big pressure from the industry, to change towards the direct anterior, because if we go back from the early 18th century, 19th century, from the Euter. So yeah, I would say that the more cases you do with your approach, probably you tend to get less releases, you tend to be more anatomic. So I think the major point here is if you are coming from the conventional posterolateral, it makes sense to go for a SPAIRE approach. I came from the posterolateral school, or the posterolateral approach, as I was resident, and I was telling you, if I'm doing revisions or fractures, so I feel comfortable with the approach. And the only thing I did, I shift my primary hips, and I do it. I would say it's a mix between, I would say, 30% direct superior and 70% the SPAIRE approach.
You're relying entirely on the posterior based approach, direct superior. Yeah. And the SPAIRE. So which ones do you prefer, the direct superior then?
I just don't do direct superior anymore, because I think I do my skin incision a little bit higher than the normal conventional posterolateral approach. So I don't cut the IT band, and I think that's very helpful for my patients with walking. I think they walk a little bit early because I don't cut the IT band. But if I have a tougher case, or that's just not a problem, because I can extend the approach. But I don't feel that what I was thinking when I changed from the direct superior to the SPAIRE approach was mainly preserving this structure, that it's the piriformis, obturator internus, and the gemelli. So I think this is a very important structure. Even for the quadratus, I don't cut the quadratus, I just retract him. And if you dissect the space, you will find the obturator externus on the bottom, and you will see a ramus from the circumflex artery, that it's crossing just near the border of your quadratus femoris. You can ligate or coagulate the artery, and then just work perfectly on the space between those two muscles.
Thank you, Eurico. Eurico, that's all the questions that we have for this session. Thank you for yet another brilliant presentation.
Thank you very much, Hitesh.
Yeah. Bye-bye.